Basically go to school for 4 years, and then we get to become Harry Potter wizards is what they turn us into. So
the hood doesn't actually go up over the head though, which is concerning.
It's around the neck.
I
Is that what
tried.
that is? That what
Yeah,
that
I did too. That was the first thing I did when I put it on.
I put.
Hello, everyone, and welcome back to another episode of the Core Consult RX podcast. And today, not only do I have one Swanson here, I have two of them.
Hello, America.
Yes, we got Ben Swanson here, Cole's older brother, right?
Yeah,
Older, yeah.
the smarter one. Yeah.
Well, I wasn't going to say it, but...
Yeah, I mean, someone has to.
You know, today's actually a National Sibling Day, so
That's
I think
what
it's
it tells
appropriate. The day of this recording. Yeah, maybe not the day of release, but yeah, I think it's fitting.
I didn't know that.
Yeah.
So do I get something? Is there a gift involved?
Yeah.
You get to be on the podcast.
Hooray.
Well, there's that, plus there's a gift basket that we give all of our gifts.
Yeah,
starting
Well,
now.
now I'm excited.
You'll see
I was
it on the-
excited already. This is going to be good.
Yeah, you'll see it on the way out the door.
Yeah.
Right.
It's not that great. All right, so, man, thanks for taking the time to be here and talk to us for a little bit.
Yeah, real glad to be here. I've heard so much about what y'all been doing, and I think it's really neat. So pleased to be a part of it.
It's fun.
So what is your background? Tell the listeners or viewers, depending on what they're watching or listening to this on, and tell them what's your background and how you got into the medical world.
Yeah, so I am a fourth-year medical student currently, graduating in a couple of months, which is scary because I still don't know anything. But I've been here, I've been in Charleston for 4 years just for school, and prior to that, came straight from undergrad. Wanted to do medicine for a long time, since high school. And I've been wanting to do primary care for a lot of that too. So that's what I'll be doing, family medicine, starting at a small community hospital in small town South Carolina in July. So real excited.
Yeah,
Very
our
cool.
graduation is actually the same day.
Is it?
Because they're both doctor programs. Yeah.
Oh, that's right.
Yeah. Saves money.
I didn't actually go to mine.
Yeah.
Really?
Mike was working, of course.
Look, I'm feeling about the same way. It's going to be outside in May.
As soon as I found out it was more than one program, I was like, nah, it's not the move.
It's not the move.
Not the move at all.
I'll do it my next go around.
Right there with you.
But yeah, I mean, I would go to the hooding ceremony. I did
That's
that.
the whole
Yeah.
thing.
Because
That's
you
what
need the
matters.
wizard cape, and then after that, you're good.
Right.
It's way too hot to be standing out there.
We've got
Yeah.
the wizard cape. I think we can just be done.
Yeah, we basically go to school for 4 years, and then we get to become Harry Potter wizards is what they turn us into. So
The hood doesn't actually go up over the head though, which is concerning.
it's around the neck.
I
Is that what that
tried.
is? That what
Yeah,
that
I
is?
did too.
didn't work.
That was the first thing I did when I put it on.
I put I pulled it out of the pack, and I was like, "What is
Still on
this?
stage. You're trying to flip it over.
Watch this, ma. Yeah, that wizard costume is crazy.
Yeah, I still
Definitely
don't know
better.
how that hood thing goes on. I looked at it, and it's too much for me. So
Well, they put it on for you, sort of like a
okay,
big ceremony.
That's they call it the hooding.
is it the dean?
Or whoever.
Okay, so they know how to do that.
Whoever they slip $20 to stand up there on a Friday.
Smarter people than me.
Yes. So, very cool.
Cool. So, why family medicine?
Why family medicine? Well, I think partially because I'm a little medical ADHD. Just can't really stick to one thing at a time. So I like getting some variety. I like outpatient-based care. Clinic medicine where you get time to talk to patients is great. And I like longitudinal relationships, getting to treat different age groups and that sort of thing. All of it, you know. I went through medical school, enjoyed everything I did. So family medicine makes sense.
Yeah.
So, what'd you think about, from when day one, you get an orientation to now, what was your take on med school? Was it everything you thought it was going to be? Was it the worst 4 years ever? What was your...
All of the above. I mean, no, I really enjoyed my time here. It wasn't everything. It wasn't exactly what I thought it was going to be. There were a lot of misconceptions coming in. It was just as hard as I thought it was going to be. I think they throw stuff at you and you're kind of like drinking out of the fire hydrants, an apt description, and y'all encountered that in pharmacy school, I'm sure. But, I think it was really good. One of the things that I didn't really imagine is that so much of medicine is watching people do things a certain way and just taking what you like and leaving what you don't. And I think med school gave a good opportunity to do that, to see a lot of different approaches, a lot of different styles, and start to formulate kind of who I'll be as a clinician.
Yeah. Do you have plans after you finish residency to do like a fellowship or anything specialized after that? Or
I don't think so. I've thought about some. If I were to pick one, it would probably be hospice palliative care. I really enjoy that.
Really?
Yeah.
I didn't know
I don't
that.
think I told you that.
That's
Well, National
interesting.
Sibling Day, there you go.
Yeah.
Well, I knew that I enjoyed being able to kind of work with families as they walk through transitions like that. And then I got a chance to do some palliative care throughout this fourth year, and really, I mean, I hate to say I had a blast with it because it, it's a very sad time and a very trying time, but to be able to hold people's hands as they, deal with those emotions and wrestle with the difficulties and be able to ease that burden is something that's rewarding to me. So
is that only in the hospice setting? I know in hospitals they're like, okay, go ahead and consult palliative for this patient. Are there doctors on board with palliative, or is that like psychologists or something coming to talk to them?
It's doctors. When they say palliative, it's palliative care trained physicians, and normally there are people with a background in internal medicine or family medicine that go through. It used to be that you could get board certified by just taking an exam, but now you have to go through a fellowship, and I think it's a year to 2 years depending on where you go. I'm very poorly informed when it comes to this, but I think that's the deal.
Interesting.
Yeah. So, I mean, historically, GPs they'd be the medical directors for hospices and things like that, but they hadn't necessarily had a lot of training in it, but now it's a little more regulated.
Yeah.
So back to med school. So med school here, at least, is 2 years didactic, right? And then two years of clinicals. Did you prefer clinicals? Most people do.
Yeah. Well, each year progressively got a little bit more applicable to what we'd actually be doing. I mean, all of it is involved. The basic sciences are important, but from first year is all molecular type of stuff and anatomy. Second year you actually get to pathology and treatments, and then third year you get to start applying it. So it all felt more relevant as you went along. So each year was successfully more enjoyable, I think.
Yeah.
Cool.
The problem is to contrast medical school and pharmacy school, I feel like in pharmacy school, y'all come out ready to do what you're going to be doing. Unless you're going to clinical medicine, you've got some more, more training. But, at least for us, I would never want one of my loved ones to go be treated by a fourth-year medical student without supervision. I mean, it's a setup. It's a foundational knowledge for residency.
I guess that's reasonable because
education.
Because med being a doctor is so multifaceted. And they assume that you're going to have postgraduate training, whereas with a pharmacist, they have to plan, even though they encourage postgraduate training, they have to plan for you not to have that. Mm-hmm. So I guess in a sense, they do have to have you prepared, but I don't think anybody ever feels truly prepared coming out of school. So
no, but hopefully not wholly inadequate either.
No, but I will say, when I first finished, I thought I was extremely prepared. And now looking back 3 years later, I realized just how much stuff I didn't know that I didn't realize I didn't know until now that I've been practicing. But it's one of those things that depends on the practice setting too. I mean, if you're going to go work in an ambulatory care or a critical care or something like that, like someone first graduating school wouldn't have a clue as to where to begin in a real setting like that. So I think it depends on the setting you're going to. Even community pharmacy, you feel ready, you feel like you're going to, rock it out. But then when you get handed those keys for the first time and everything's on you, it is a little bit different.
I realized I needed to ask my pharmacist, where do I get the keys from? Because I'd never been there to open up and get the keys, and I'm going to start working soon. So
here's a quick sidebar. In the previous episodes of this that I've seen, there's been a theme song and like a cool graph that comes on the front. When does that happen?
Wait a minute.
Post-production.
You're not supposed to tell them that it didn't actually happen beforehand.
But he never said, cue the music.
Yeah,
because I've seen that in the past. Well, it's going to be there now.
So even though we say no editing afterwards, I guess there is some.
Well, yeah, there's post production because I like mess with the look of the video, and I do add some.
So you mostly I just outed you. Well, I just wanted the opportunity to give kudos to the theme music and ask where it came from because I thought it was pretty good.
It's a good question, actually. So I know where it came from, but
my little brother wrote it. So
did you really?
Yeah, he's my 19-year-old brother. He's makes beats and produces music and all that, so he's pretty talented.
Well, there you go. Shout out to Mike's brother on National Sibling Day. You're welcome.
There you go. Boom.
There you go. It's all a ploy.
Tying it all in.
We'll give him a shout out. So check him out, Telquel on Instagram and SoundCloud and Spotify and all those good things.
There you go. Happy National Sibling Day.
Yeah, so that's who I usually get most of the music that I do for Instagram or anything like that. That way I don't have to worry about anybody coming after me.
All those copyright things.
Yeah.
Whatever that means.
Yeah. So for him, I mean, he can come after me. I'm faster than he is, so let's run away.
So basically, you just wanted to rock out to the music for like 5 seconds.
Yeah.
More or less. Yeah, I was really excited about it.
It's coming.
Well, we'll play it. It's
post production.
Great. Yeah, we'll show it to you. Anyways,
we're professionals here.
I've gathered that very quickly.
Yeah.
Look at this beautiful studio.
Yeah. Well,
it is exciting for me. I've never podcasted. Is that what it means when you're making one or when you're listening to be podcasting?
I think podcasting
Or
is like
both.
actually produced. I don't think there's a set.
I think if you're listening, then you are a podcast listener. You're not currently
You're not
podcasting.
podcasting.
If you're recording, then you're actively podcasting.
See, I'm new to the game. I'm learning.
Yeah.
Yeah.
Thank you for the clarification.
Well, we have a handbook that we'll.
We'll give you.
I haven't
We've
seen the
read it
handbook yet.
very thoroughly.
Yeah, and by that we mean not at all. Went through 2 pages. Decided it wasn't the move.
Not the move.
Oh, anyways.
So how does this go?
So, well, funny you should ask. This is about what we do. We say, hey, what should we talk about today? And we go, yeah, that sounds cool. And we talk about that.
And then we talk about it.
Yeah, we have no rhyme or reason. We don't really spend a whole lot of time in kind of going over what we should be talking about. So, yeah, that's why sometimes our podcast either ends in like laughter or
only like a minute of laughter straight without stopping. That happens every once in a while.
That was good.
Well, I'll tell you what I'm interested in talking about, if you don't mind.
Of course, let's hit it.
So I'm here in part to learn because I haven't been a clinician yet. I've been learning to be one soon. I'll have my own panel of patients. I'll be prescribing. I'll be talking to you guys a little bit. And I want to understand that interaction better. I had an opportunity to study it a little bit recently as part of kind of a health economics class where I got to delve into health information technology. And so a big part of that was looking into the development of electronic prescribing and how that's progressing into prior authorization and that sort of thing. And so what I want to better understand is how we can make our interactions a little bit more efficient and how I can kind of learn the things I need to know to make the time valuable for y'all as well as for the patients and myself when we're talking through prescriptions and that sort of thing. Because we'll spend a lot of time on the phone, I think.
Mm-hmm.
Hopefully less.
Or at least your nurses will spend a lot of time.
Yeah,
on the phone.
nurses as well. So from your end, how long have you been practicing pharmacy?
3 years.
3 years. So I think the big kind of health information technology wave came about 10 years ago. 2007, 2008 it started hitting. Have you seen any big progressions, any changes since you started?
E-prescribing has become
e-prescribing.
huge. I mean, it was already there when I was first practicing, but
Been catching on more.
it's going, I mean, my pharmacy does almost exclusively prescribes.
Yeah. And I mean, this saves so much time. I don't know what the laws on the books are now, but I think like there are some mandates to have that software available in a lot of settings for doctors to be able to do, just because it decreases errors, it decreases time for transcribing for the doctors and the pharmacists or pharmacy technicians, whoever's doing it. And before, you couldn't really e-scribe controls, specifically C2s, but now, at least in our state, I'm pretty sure you can e-prescribe C2s if you are set up with it. And I think it's an even more secure system to be set up for that. So it definitely saves time and saves people money. And there's no confusion. Well, there can be confusion, but because sometimes they're sent to the wrong pharmacy and whatnot. Whereas, so some patients will say, no, I want hard copy prescription so I can take it where I want and shop around. But yeah, overall, definitely a positive thing.
Well, and it's interesting to get a pharmacy perspective on this because y'all kind of led the way, spearheaded adoption of these technologies. I think they legalized the prescription of controls electronically a number of years ago, but it takes a long time for doctors to catch on to these sort of things. We're sort of stuck in our ways, I guess, for a multitude of reasons. But it's clear from studies that these things are good for patients. It increases adherence. It's good for efficiency, for healthcare spending, that sort of thing. It streamlines, at least in the prescription realm, most every part of the process. There have been other things with EMR where, they thought it would cut down on useless tests, but it didn't, and that sort of thing. But at least with drug prescribing, it seems to be better. And they're taking steps forward. So it's going to be exciting to see how that goes. What I looked at in particular was electronic prior authorization. So let me hear from you just first off, kind of what your experience is with prior auth from the pharmacy side.
I mean,
you want to go for it? Generally bad experiences. So what happens is the doctor prescribes a patient a prescription because it's, maybe the best medication for them. PAs only come into effect if a patient has insurance, of course. So they'll bring us the prescription. We will bill it to the insurance, and then they'll spit back and say, no, we need a prior authorization from the doctor before we're going to cover it. So basically that means that the doctor has to probably fill out a one-page form saying that they may have tried this medication or this medication, basically saying that this patient is indicated for this, so you should pay for it. They submit that to the insurance company. The insurance company reviews it. There might even be a clinical pharmacist on the other side reviewing it also. I've known some who do that. And then they'll say, yes, this is indicated for this patient, and they'll approve to pay for it. And then they either contact us or the patient contacts us out of exasperation, and then we try to run the claim again, and the claim goes through, and yay, now their prescription's paid for.
So you'll probably get a lot of grief.
Oh, every day. And it's over the course of...
is it really every day?
Oh, it's absolutely every day.
100%.
It's multiple times a day. And it's over the course of multiple days that this process goes, with the patients calling us every day. And we kind of have to, we don't want to try to make you guys sound like the bad guy, but a lot of times it's like...
It's contingent on us to get...
Well, it's like, we've sent them information, and so until they submit it and the insurance approves it, it's out of our hand. Have you had similar,
The big thing I run into is the patients, don't know what a prior authorization is.
Right.
So the big comment that I always get is, well, it's authorized right there. My doctor wrote the prescription for it. So education and how you word, the definition of a prior authorization is important. So I spend time with my technicians kind of going over that, because if they just say it's a prior authorization, the patient has no idea what that
usually
means.
They'll say, oh, it needs a PA. And the patient's like, what in the world
I saw
are you
a
talking
doctor,
about?
I didn't see a PA.
Right, exactly.
And so, I think that from that aspect, it just is a communication education type of thing. And then from there, the places that I've seen that get the PAs done the quickest are the ones that have actual departments that are there for that process.
Yeah.
So like Palmetto Primary Care, for instance, is a big franchise around here. There's a lot of family medicine. They're usually pretty quick about getting prior authorizations done, because they have a department that handles that for centrally, and then they'll call and say, hey, I'm from Dr. So-and-so's PA department. You can rerun it through. So that helps us, because now we know that you actually did it, as opposed to if I have 500 prescriptions, I can't just be sitting there rerunning that one every 30 minutes, because it just gets lost in the confusion of everything.
Right.
Well, they did a study that showed that for every physician, there is 16 hours of staff time that's devoted to processing prior authorizations. And that for every pharmacist, there's another 5 hours at the pharmacy that they spend handling PAs or talking to patients about PAs. Does that sound about right?
Yeah, and it would take a lot longer, except for the company I work for, they handle it centrally. So we notice that it has a PA, so that 5 hours is probably us talking to the patient, taking phone calls, following up with insurance companies or y'all, but we actually are able to just say, okay, it needs a PA, and we have our central, essentially, office handling that. So there would be a lot more for us to do if they didn't do that. So like independent pharmacies, for example, don't have that luxury, and so they have to take that time, contact the doctor, fax them a form, whatever, and follow up with them over the course of a few days to make sure it gets done, or that patient's not going to have their medication, and they definitely won't have it till the PA is done, which is easily multiple days.
And a lot of this still does involve fax, which is fascinating to me, rather than doing electronically. And that's what they're kind of working on, and what I was looking into is how more of this can become, if not automated, at least electronically, distributed. We're doing 5 billion prescriptions in the U.S. now. Most all of them are electronic. 185 million involve prior authorizations. Electronic prescribing has been wildly successful at increasing efficiency, and you would think that getting prior auths to that would bring around the same benefits. So they're trying to get it involved in the EMRs now, integrated into the EMRs. So the reason I was looking at this in the first place is, from a doctor's standpoint, I get very frustrated with not being able to know what a patient's going to be paying when they go to the pharmacy. I know that y'all get a lot of flack probably from patients who are showing up and it's a lot more expensive than they thought it was going to be, right?
Mm-hmm.
Oh, yeah.
Do you see patients walking away and not taking prescriptions because they're kind of turned off by the cost?
100%.
And so that's an adherence issue too. So that's not, it's inconvenient for them, but it's also a cost to the system when they show up in the hospital because they haven't taken their pills. And so it seems a lot of that could be resolved if at the point of care, a physician's able to see, enalapril will cost this versus lisinopril, which will cost this. And so you would think with all the technologies that we have, we'd be able to get to the point where a doctor could see that, right?
Yeah, I think so.
Because is it pretty instant for y'all?
Yeah, ours adjudicates in real time. So
Sure.
when we send a claim, it goes through immediately. As far as the physician's office being able to see, because you're not actually billing the prescription,
Right.
Because that would then take up more time doing that.
Yeah.
There is a app available.
Is there?
It's called Formulary that you can check the patient's insurance, and it'll tell you the medication, which tier it's in.
Right.
And I don't know. I haven't gone too in depth with it to see where it kind of cuts off or where it misses the mark or whatever. But from people that I've talked to several people who use it quite often, and it's supposedly pretty accurate.
Yeah, and it's very handy, but I will say to what you're describing and to what formulary does, it might tell what it is and what tier it is, but not necessarily what it costs.
Yeah, no.
And not what it costs to specific pharmacies. And even if it's covered, like, oh yeah, it's covered, but you got a $50 copay.
Right.
Every month, a lot of patients still aren't going to do that.
There are some EMRs that take it a step further and give you a cost, but it's a static cost. It's kind of a generic, this is sort of what the company would charge, but it's not active. It depends on what kind of insurance the person has within that program. It depends what pharmacy they go to. And so optimally, you'd be able to get a real-time benefit inquiry is what they call them, where we submit it as if we were billing and we get back what the real cost would be. It's a long ways down the road, but they're working on it. I think it would be.
Has that happened anywhere yet? I mean, you mentioned that some states might be adopting similar programs.
Well, it's kind of on a national level. It's gaining traction. Humana, I think, which are they a pharmacy benefit manager? Yeah. So they're a PBM, and they worked with a company called Dr. First that has a program called My Benefit Check, and it basically did that. And they've been using that almost as a pilot to study how these things work. And rack up evidence so that it can become more widely adopted. Recently, CVS Caremark announced that they're rolling out the same thing for any of the patients that deal with them. At least the data will be available for providers to access if providers have that sort of thing in the system. Of course, they won't probably for several years. It's going to take a lot of convincing and marketing to get doctors to sign on, as it has with any technology. But ultimately, it seems like it's, really helpful that they're making that technology available for use.
Yeah, I think the first, like what you mentioned, the reaction to them finding out the price would be, oh, well, they would have to bill for the prescription and submit an actual claim, which is just a whole big thing because then you have to get like qualified to be able to bill for prescriptions, which doctors' offices aren't. For instance, they bill Medicare Part A. Okay, is the outpatient provider, and we bill Medicare Part D generally.
Right.
And so they're not set up to bill Medicare Part D.
Well, that's the thing is it's not an actual billing.
That's what I'm saying.
It's like a simulated.
Right. So it would have to be something in the middle that isn't just them saying, okay, this is covered, or billing the actual claim. It would have to be, like you said, a pseudo claim that would actually spit out a real number.
And so what it seems to involve is a third party that's basically integrating with the systems of pharmacies, of payers, of providers, and drawing everything in to kind of mix it together and spit out this data in real time. And so, of course, that involves a cost. It's going to be a cost to pharmacists. It's going to be a cost to providers to pay these third parties like SureScripts or whoever else, Cover My Meds might do it too, who are going to provide the information. And so will it be worth it? How much will it cost? These are things we don't know. But it seems like it offers some value.
Yeah.
See, the other big issue that I've seen as far as prior authorizations that there's really no way to, I guess, combat it is, you have these drug companies that will do deals with the insurance carrier. Mm-hmm. And so, for instance, they may have a drug like for GLP-1s for diabetes. They may have Bydureon that's their preferred GLP-1. It's a once-weekly dosing regimen. But if you look at the actual data, the Trulicity, the dulaglutide, is the only one that's been actually shown to be, or not the only one as of now, but it was for a long time the only one that was approved, like non-inferior to the market leader, Victoza, which is a once daily. So it was the only one.
As far as cardiovascular effects and benefits.
And
right?
A1C lowering.
And A1C lowering. Yeah.
And then when semaglutide came out, now that one also is non-inferior and actually maybe even superior at this point. But they're not looking at the data from that. They're looking at it from a business standpoint of, okay, well, I'll cover this one, even though it's an inferior product. And that's, that's something that's definitely causing an issue. Right. But then how do you solve that? I mean, you're going to have legislation that affects a free market, and that's, I'm not really a fan of that either. So that's just a problem that's, I don't really know how they can fix that.
Right. So as a clinician, you would want to prescribe the best drug for this patient, but they're preferring a different one in the class that may, that in their mind it's like, hey, it's the same class and we can cover this, and that's how it was pitched to them by the drug company, but it might actually be a lesser medication. And this is a little off the topic of the PA situation.
No, I don't think it is.
Goes
at
to
all
a bigger issue.
See, I think it stems into that.
Yeah, absolutely.
Okay,
because,
I guess it does.
Yeah, the trick is
Cole.
I'm not calling you out.
The trick is that the best drug for the patient, in theory, it's the one that performs the best in clinical trials, but in practice, it may be the one they can afford and have good access to and will take. And so that's what we're kind of figuring out on our end. And so when you're thinking about something like a real-time benefit checker, what that does for us is to say, okay, keeping in mind this person's situation, how much money they have, what their social situation is it going to be better for me to be able to assess at the point of care what's going to be more affordable for them and give them what I know they will take, rather than, having them end up at the pharmacy with the number one drug, but realizing they can't pay for it and me not figuring out. Because y'all find out when a patient comes and isn't going to pick up their drug, y'all know they're not going to take it, but a lot of times they won't tell us, especially if it's an elderly patient. If it's a 30-year-old suburban mom, she's going to call us and she's going to, but if it's an elderly person, they're just going to say, well, I didn't really want to take it anyway. They'll go home, and then we find out 3 months later at the follow-up.
Right.
And so if these things could be sorted out ahead of time, it's better for patients, it's better for the system. So that's why I'd like to see these things catch on.
So you have to take into account all those things. What the side effects? Is it going to be best for this patient with this disease state? Are they going to take it? Do they want a once weekly injection, a daily injection, a pill? And so you choose the best medication for them, but you also have to incorporate costs in there, even if they have insurance. And I mean, cost does need to be a consideration, but I guess it's what we're saying is it's just frustrating where you might get all those ducks in a row, and then even with the insurance, they're preferring the other drug, which the patient isn't going to be adherent to and they don't want to take, and isn't the best drug for them generally.
That's the problem I see with some of the newer agents is the ones in that class will all be very similar in price, but the drug company has done a deal with the insurance company, and so they get a kickback, and so they prefer an agent that may be more strenuous to reconstitute or more cumbersome, more side effects, whatever, but that's the one that's preferred. And so in order for them to get it paid for, you have to give them the crappier medication, and that's a rough spot.
So here's an interesting question I have, because at least in my realm, PBM is kind of a dirty word. Kind of the shadowy figure in the background that's orchestrating all these deals and leading to prices being, like they are. What's the perspective from pharmacists on how pharmacy benefit managers work and the role they play?
I think it just depends on, who you ask. I mean, I think that there's definitely, just like anything else, there's some quote unquote shady things that go on that's definitely not putting the patient at the center. But then if you look at how pharmacies do certain things, that's not putting patient care at the center either. It's
because you have business managers at the head of most of these things, and
the problem is you have to still run the business, because if the business isn't profitable, it goes away and then no one's getting help. So I understand that side of it as well. I'm not hating on the CEO or anything like that. It's just I think that there needs to be just more, I guess, talk about using evidence-based medicine to make some of these decisions for formularies, so they're not running into some of these issues more so than these kickbacks or just picking a random drug. And so I don't know if that means getting more and more pharmacists or physicians like on board that work for the drug companies in order to have them pick the best formularies. Because ultimately, like someone with diabetes, if you can lower their A1C better with one agent versus another, if it costs them about the same, in the long term, you would get more benefit from lowering their A1C with the other drug that's better versus like a short-term kickback. So, if you had these pharmacists or physicians that could, put this data together and actually present it in a picture that's like a long-term cost-benefit analysis, I don't know if that would make a difference. Yeah, I don't really know what the answer is to...
Or if they had similar A1C lowering, but one might have more cardiovascular benefit than the other long term, that's going to save them money. And maybe the effort towards more quality-based care and reimbursements might make a difference there. It is just a tough thing to go to work around. But to your point about the PBMs and the big pharma, I might take a little flack for this, but so when I think of PBM, I think of the insurance company, right? And then there's big pharma, which are separate, and they kind of, yes, I know PBMs are a little bit different than just the insurance companies, but it kind of gets things into people's heads. And then big pharma is the people who have to put on the clinical trials, and then they create these new drugs, and then they put the drugs out there, and then they have to make money too. To me, I have more of a salty taste in my mouth with the PBMs than I do with the big pharma. because the amount of money that these pharmaceutical companies have to spend and be willing to put out like big risks up front to get these drugs approved and created, I don't think they get enough credit for that, because FDA approval is no joke.
Sure.
And then after that, they have to end up making a profit, or there's no one to make the drugs. And so, I mean, you know, for the whole extending patent thing and all that, you know, there's definitely controversy around that, but they do need to make their money back, or there's not going to be anybody to make these drugs. It really gets to the PBMs and the collaboration and the shady deals where a lot of my issues arise.
Right, because you have to consider that you look over at, you know, England or any European country, and they're paying a lot less for these drugs than we are, even though the R&D costs are the same. So there's something complicating the picture, and it's hard to know exactly what it is. I will say that when we consider costs as physicians, another important thing that we haven't considered historically is not just what's the cost to the patient, but what's the cost to the system. How can we be responsible with healthcare economics at large? Because provider behavior, prescriber behavior is going to be a big part in cutting down on costs and making it more sustainable in the future. And that picture is complicated by having all these middlemen sort of between manufacturers and between patients. It doesn't make us feel accountable because we're not really seeing prices. Mm-hmm. Y'all are seeing the prices, and patients certainly don't feel accountable. I saw a patient in clinic like a year ago. Maybe it hadn't been that long. When did Xeljanz come out?
At least 2014, I think.
Okay, so it was like a year ago. Patient had gotten Xeljanz. It's like a $70,000 medication or something. I forget if he got patient assistance or whatever, but he never took it. I mean, he didn't have any skin in the game. You know, someone's paying for this behind the scenes.
Yeah.
I was a dermatology clinic, funny enough. So, you know, someone's paying for it, but he doesn't have any concept of what these pills mean, what the trade-off was for this. And so, you know, he doesn't feel any compulsion to be adherent and to follow through with the treatment plan that's been prescribed. So finding some way to bring some concept of the cost to prescribers and to patients is going to be, I think, very important in changing prescriber behavior to make it more in line with our value-based care goals.
Yeah, that makes sense. And to the point, just a small point about being responsible with overall healthcare costs, copay assistance cards should probably be a little more controversial than they are. Because for one, you know, you can get this patient to afford this really expensive medication for maybe 1 month or 6 months, even a year. But then after that, they're on this medication that they like, and then they're going to have to pay a whole bunch out of pocket or come off the medication and be non-adherent. That's a consideration. Also, you have to think, so some people are still getting paid when you use a copay assistance card. The people who are still getting paid are potentially, like the drug companies might have a deal with the insurance companies, or because they have to still pay the pharmacies and whatnot. So a lot of the burden of those goes to the overall healthcare insurance industry, and they're not just going to eat that money. What are they going to do? They're going to put it out on other people, and it's going to
raise premiums.
So that's definitely a consideration when you're thinking about giving somebody a copay assistance card. I'm not saying they're totally evil, but I think it needs to be considered, because I don't think a lot of people, pharmacists, prescribers, anybody really thinks about the fact that we might be raising everybody else's premiums by getting this patient this expensive drug for a couple months.
Right. And what do copays do? It puts a little bit of skin in the game for the patients. It may also be prohibitive and, you know, and keep them from getting medications they need. So that's important. But copay cards just eliminate whatever function copays would have served.
That's true. So that's why would they make you pay $150 for a really expensive medication, is because when somebody pays money for it, they feel a little more attached to it, and they might be more compliant with the medication for sure.
Oh, well, they've shown that. Like sometimes free clinics that give out medications to certain patients, it's on an individualized case. Some patients will be more adherent anecdotally. If they have to go and not even pay for it, just pick it up from the pharmacy, Walmart free, or, you know, Publix free, I guess, rather than having it dispensed at the clinic. Just having to put in the effort to go out and get it makes them feel like they're more a part of their treatment team, you know. So there's something to that, I think.
Interesting.
For sure. What do you think about a model, and I've heard this, and I hope I don't butcher this, but I've heard about a model where certain prescribers will have almost like a membership to their clinic, to where instead of using your traditional insurance, you pay like a monthly fee or a yearly fee where you can come in and you can see the physician when you need to. And so some people, just like anything else, so it's more like insurance through the actual prescriber.
Yeah.
So skipping the middleman of the insurance.
Exactly. And so if you fall on, break an ankle, you can go to that clinic and be seen because you've been paying your monthly bill. Or, if they have a dispensary or even a small pharmacy attached to that, ahead of time what medications you guys stock and which ones would be best, so that there is no formulary changes or having to switch things around or PAs. And then the patient pays that as part of their cost, and then different levels or whatever their membership would be.
I think it's a pretty neat thing. It's a movement called DPC, direct primary care. You hear some subset of it referred to as concierge medicine, and so that gets a specific type of connotation as well.
Are they the same thing? Or because when I hear concierge medicine, I don't think of a full clinic practice. I think of a doctor who might have like a small office and like one staff member.
Right. And so to picture a specific way this is done is a little bit off, because there's no set standard for it right now. It's kind of an evolving movement. And everyone sort of does a little bit differently, and a lot of it is contingent on how the doctor sets it up. But the general idea is you're cutting out insurance. The patient is dealing directly with the doctor, and like you said, they pay a subscription fee. It might be $50, $100, $150 a month, depending on what service they're getting.
Might be $500 a month, depending on the doctor.
Might be $500 a month. And that's when we're getting more into concierge medicine, perhaps. But what it does, it allows generally unlimited visits to the doctor. There are smaller patient panels, and so generally you can get an appointment very quickly rather than having to wait several months. And you pay in cash for whatever you have done. And so a lot of ways this is good. Patients can get the attention they need. If they don't need as much attention, they don't end up paying for as much. If they break an arm and come in, they only pay for the cost of the casting materials. It's $8 or whatever. And so it cuts out a lot of the administrative burden that would otherwise add costs to healthcare. What it means, though, is that doctors have to have a little bit of a talent for organizing things like laboratory services and prescriptions and that sort of thing to have those available. And so what a doctor will do to make labs affordable without insurance is they'll go to LabCorp or whatever, and they'll say, look, I'll bring you the business of this whole patient panel if we can work out kind of a deal on a kind of fee-for-service type of thing to make this affordable for my patients. And so that's what they'll do. And
is that ethical, or is that almost like a kickback? Like, you give us a discount and I'll send my patients to you?
No, because the discount's to the patient, not to the provider, is the idea.
They're not getting any money in return for sending somebody there.
Right, okay.
Right. And so the reason LabCorp likes it is that often what will happen, not every time, but what will happen a lot of times, is that LabCorp won't bill the patient, and they're not billing insurance. What they'll do is bill the provider. So the provider will collect the fees and then pay LabCorp. So LabCorp isn't worrying about, when am I getting my money? Am I getting my money? Do I have to pay for collections if people don't pay? They know that you're good for it, and so they're willing to give you a little bit of a discount on it. And so you do that with imaging, you do that with labs. You might work out some deals with specialists too to get colonoscopies and that sort of thing done. Specialty care gets a little bit more complicated. But overall, it simplifies the process for patients. And not only are you taking the administration of the insurance out of it, but also for the doctor's offices. Normally, they only need 1 or 2 staff members to handle all of this. When you start getting into the realm of concierge medicine, that's when you're talking about doctors who practice traditionally for a period of time, develop a big panel of patients, and then say, hey, you have to pay these exorbitant fees to make it into the select few that are going to be able to remain my patients. And so, that's more of a lifestyle thing than anything else. But direct primary care itself as a movement seems like something that's valuable and takes out the middlemen. So I think it's interesting.
So would that discourage them from maybe ordering labs that a patient might need or procedures because they know that it's actually coming out of their pocket and not the patient's at that point?
It's not coming out of their pocket. The patient pays for the lab. They pay face value for the lab.
Oh, so LabCorp just bills the provider, but the patient, and then the provider bills the patient.
Right.
Okay. Gotcha.
Yeah. So basically LabCorp likes it because the provider is the collector.
Interesting.
But yeah, I'll order whatever test I need to because I'm not paying for it. But I'm also, they're one of my few patients that I'm trying to care for as best I can. Mm-hmm. So I'm not going to bill them for something or, prescribe something that I don't think they need. So I'll be a little bit more careful with it.
Yeah, instead of just ordering, just get all the labs. Who cares? We'll bill Medicare. I think I mean, this is me kind of just guessing, but I'm thinking that if the patient is responsible for the actual payment of a lab, it's going to put them in a position where they maybe want to know more about what that lab is, and it gets them more involved in their actual care.
That's a great point. I think absolutely so. And I think in a model like this where you have less moving parts and more room to kind of act autonomously and shape your practice, you could start to bring in other sorts of providers and get them involved, and you could start to see where can I find value in education, and that's where I think pharmacists could ultimately come in. And so that's what I want to understand a little bit too. I hear a lot about kind of the role of pharmacists in the clinic expanding along with PAs and NPs and PTs. Legislation is changing and that sort of thing. It seems like y'all get more exposure to sort of the legal environment and the milieu. We don't really talk about that a whole lot. We know that there's the AMA lobby or whatever, and we get the solicitations to contribute, but we don't really hear about that. So, tell me from your perspective, what should I know as a physician about how the role of pharmacists will continue to evolve?
So, I think the big push right now is obviously for provider status, so we can bill insurance companies as a provider. And I think the big pushback with that is the thought that it's going to take away from job opportunities for physicians or take money out of their pockets in the long run. And I think, where pharmacists are frustrated, I can have a patient come in to me, sit down and spend 15 minutes going over their diabetes medications. They're showing them how to use their meter, whatever it is. If I was in a physician's office or if I was a physician, I could bill the insurance for that and actually get paid for my time. Versus a pharmacist, I have no way of doing that. So I just did that for free for no reason. And so there's no financial encouragement other than just doing it out of the goodness of your heart.
Right. And there are some pharmacists who won't. They'll say,
exactly. I don't get paid for that.
Just take that and go.
Sure.
And that's not the way to be, but at the same time,
but I understand.
Obviously you have all these other things to do. You need to have some sort of a reimbursement for the time. Just like we're coming from a spot where the pharmacist's job has evolved so much in such a short period of time that we're kind of like in this weird like limbo.
Yeah.
Where I don't think the general public kind of understands what even a pharmacist does. And I mean, I had somebody ask me if I went to the technical school to get my pharmacy license. Like I went to a 2-year program, and I said no. I got my bachelor's degrees in biochemistry, and then I got my doctorate. And they're like, a doctorate to count by fives? I mean, that's the no. And I was like,
count by fives, lick and stick.
Yeah, that's all it is. Big bottle to the small bottle.
I mean, to people's credit, especially people who are a little bit older, I mean, not too long ago,
right.
That is what we did, and that was it was discouraged for us to counsel the patients. It was like, can you tell me about this medication? Well, what'd your doctor tell me? Well, they said it's for my gout, and then you look down and it's like, well, this is a placebo. Yeah, it's for your gout, because placebo prescribing was legal back then. Mm-hmm. So things have changed a lot. Where now, I mean,
they wouldn't say it out loud, hopefully.
Okay, in their mind, in their mind's eye, they would say, these
are M&Ms.
These are M&Ms. Here you go to help your gout.
That's right.
So, yeah, in that sense, people's view of pharmacists would have to change, and if they haven't had much interaction, then I guess it's hard for them to know what we do now.
And something that really baffles me, and this is more just confusing as to why this is, but I have no desire to necessarily go by doctor, but we have doctorates. We're the only group that has doctorates that does not, unless you're in an academic setting or something, like we're the only ones that are like, if you go by, Dr. So-and-so, you're looked at as almost like pretentious or like kind of a jerk. And I'm like, chiropractors do it, dentists do it. The PhD with carrying the thing of rats. I mean, down the line, like they do, and there's nothing wrong with it. They have a doctorate. Like, I just don't understand why it's like so frowned upon for pharmacists. And other than the fact that it wasn't that long ago that we didn't have doctorate.
Yeah, I guess PT might be similar because I don't know that people would generally say.
See, the PTs that I know, they go by doctor as well. Really? Yeah.
Oh, there you go.
So I don't know, and again, it's more so just out of curiosity. Like, why does it like? It's like, well, you're just pharmacy though, kind of. And that's where I don't like, because I feel like too many pharmacists get comfortable just taking that position of like, I'm just a pharmacist, whatever, and it hurts the profession because then we don't get anywhere, we don't grow, we don't show our worth, we just accept the fate.
Right. And I mean, I don't think either of us really care if somebody calls us
Right,
doctor.
I don't.
But it goes to the larger public perception.
Exactly.
For sure. And going back to like what pharmacists do in a clinic setting. So he mentioned that we don't have provider status. So there's a lot of people who have that, and that just makes it a lot easier to bill Medicare and Medicaid. So what we have to do, if we see a patient, say they're on the schedule and we see them for a diabetes follow-up, we have to bill incident to the physician, which means the physician actually bills for that visit. We just have a protocol with the physician that says, yes, this pharmacist can see these patients. I will sign off on their notes, and it's okay for them to prescribe medications related to diabetes or related to their blood pressure or whatever, and we can follow up on that. And so that is one way where the doctor didn't have to see the patient. We saw the patient, and then we just made him money. Not only that, but within that, we are, or him or her money, within that, we are able to bring money to the practice, and then they also have a pharmacist on site who is just a resource, because why wouldn't you want other healthcare providers in the setting so you can ask them questions or whatever, and if they want you to come in and counsel a patient and talk to them, then hey, we're happy to do that for sure, because a lot of what we do is in that setting is to be a resource.
So there will be reimbursement to the physician, and the physician pays the pharmacist. Is that how that works?
So we would be like on their payroll, and similar to a PA. So a PA, even though they can bill, it's a little different because they are providers, so they can bill independently. They just have to work under the supervision, quote unquote, of a MD. We have to work under the supervision, and it's not actually us billing. The physician is billing. It's just legal.
I see.
For us to see them without the physician.
So the goal would be for you to be able to bill independently so that you could do it out of a pharmacy rather than having to be...
Not necessarily out of a pharmacy, still potentially in a clinic setting, because, I still think that doctors would have issues with us just seeing a patient, because we would still have to have a collaborative practice agreement with a physician. We could just bill independently.
Right, but at least to be able to bill for educational time that you do in the pharmacy.
Or it would bring us more to the table. If you own a clinic,
right,
and I come in and I say, hey, I can provide diabetes education, I can provide smoking cessation, whatever the case may be, but I actually can't bill for any of it. So you're going to have to pay me for all those things, and we just hope we break even.
Right.
That's where I think a lot of pharmacists are struggling, because we can't bring that to the table.
Right. And I mean, so that's the future, is the provider status. But even now, pharmacists are able to make it work. There's a lot of clinics where they do see anticoagulation patients, COPD asthma patients, diabetes, hypertension, hyperlipidemia patients, and bill. Some of what the providers have issues with is like with Medicare, sometimes the reimbursements are a little less if we're the only ones that see them and the MD doesn't see them. So that is a consideration. And, we'd have to have a lot of patients on our schedule too to justify a full and real salary. But there's other things that we can do like outside of that. Like there's continuity of care management, CCM, I think that's what it's called. That's one thing that we can do that is billable under Medicare that brings in revenue. We can do other MTMs and things like that we can bill certain programs for that brings in revenue. So there's a lot of ways that we can. We would just have to be able to pitch ourselves well to the practice and be able to work in that setting. And in the community pharmacy setting, it's a little more difficult. But yes, if we did have provider status, then there would be an option for us to do a little more than just MTMs and be able to bring a little revenue for that. I don't know if doctors would feel comfortable with us seeing their patients in our pharmacy away from the doctor, but there are other things that we'd be able to do.
So on the legislative front, is there progress being made towards provider status?
It looks like there's already enough. I'm trying to remember. We get these emails. It's through, I'm terrible with politics. It's through one of the big things, the Senate or whatever, and it's got to be voted on by. You're laughing because I don't know anything about politics.
Big things like the Senate.
Either way, it has the support, and it looks like in the next couple years, hopefully, it will be able to go through.
Well, that's good. It seems like a big part of that would be accumulating evidence that a pharmacist encountering a patient for diabetes education, smoking cessation, that type of thing adds value and changes outcomes. And so is that something that's kind of been developed?
Yeah, I'm sure there's studies.
Yeah, there's lots of studies that have.
Or at least
I would imagine there have to be. Yeah.
Or at least we so we see this patient and we free up the PAs or the MD to see a different patient that they can bill more for.
Opportunity cost.
And
economics.
And so even if we are billing and we're getting the same reimbursement as a PA, you're having another presence in the clinic who's a clinical resource, which there, of course, PAs are clinical resources and whatnot, but it's just diversifying your workforce a little bit and having some other options and some other, people that you can consult.
There was one article I was reading about health technology, and it mentioned robotics in pharmacy.
Oh, yeah.
Doing like pill counting and stuff. Is that a thing?
Oh, yeah.
I have a robot in my pharmacy.
Do you really?
They're all over the place. Yeah.
See?
So a lot of pills they will count. In hospital pharmacies, there's a lot of robots and a lot of other pill dispensing things. But so there's like people are like, oh, that's going to take the place of a pharmacist. It can't really take the place of a pharmacist.
Well, I saw it more in the context of it'll free up a pharmacist to attend to more clinical duties.
Sure.
It seems like
so that is definitely something that it could do. I think out west, somebody who's out west, let me know if this is a thing. But I've heard of people going into a pharmacy and it's a kiosk that dispenses a medication to them that a pharmacist has checked like remotely from a different location, which is
like that.
Interesting. And if they can come up on a camera and counsel the patient on it. Or a screen and counsel the patient on it.
I mean, it'll never be fully automated because you have to have a human overseeing. I imagine interactions and things like generic and therapeutic equivalent substitution and that sort of thing.
Right, but it would fill us up more for clinical duties, and unfortunately, the jobs that it would take would be like a pharmacy technician more so than the actual pharmacist.
That's probably true.
The thing I'm really curious to see, I don't know what Amazon's plan is to kind of whether they're going to get in the space or not, but, like for instance, the Alexa show, if Amazon does decide to bring in all these pharmacists in their payroll and start these, online pharmacies or whatever, to say, hey, Alexa, let me speak to a pharmacist and have that pharmacist pop up in real time on the show or the physician or whoever. I think telehealth in general is going to be huge, but I think Amazon's already working that front, and I'm really, really curious to see how that plays out in the not too distant future.
Yeah. They're doing their own like health insurance thing. That's going to be fascinating.
Yeah. It's interesting.
Getting their hands in everything now.
Well, cool.
Yeah, that was good.
I'm always fascinated to learn about this stuff because I know nothing about it. I'll talk sometimes like I do, but I don't. So sorry if you get some angry fan
That's
mail.
what we like to see, doctors who don't know anything. So.
Well, you remember VeggieTales, the pirates that don't do anything?
Yeah.
I'm the med student that doesn't know anything.
Okay.
That was a 90s reference, I think.
Yeah, look at me.
Look at you go.
Yeah.
That's cool. All right, man. Well, I appreciate you taking the time to do this. Let's do it again before you head off to residency.
Yeah. Just a couple of months. I'd love to.
Yeah.
Cool.
It's fun.
All right, you guys. Thanks for listening. We will catch you next time.
Happy National Sibling Day.
There you go.